The NHS in Wales is facing some really big challenges, and in November 2011 the Welsh Government published its 5-year vision for the NHS called Together for Health. It sets out just what those challenges are. The Minister has asked every health board in Wales to produce a plan for providing services that are sustainable, safe and as good as the very best. Here in ABM University Health Board we have a programme called Changing for the Better. It's a whole lot of people working together with patients and representatives of our community to develop a plan that makes our services sustainable, safe and as good as the very best. And here we can see no reason why we couldn't be providing world-class care for everybody that uses our services. In this short film, clinicians and patients talk about how we're addressing those challenges here in ABM University Health Board. We hope you find it interesting. At the end of the film we tell you how you can find out more information and how you can be involved, and we really hope that we hear from you about your thoughts and your experience of our NHS.
My name's Colin Ferguson. I'm one of the vascular surgery consultants in Morrison Hospital, and I also represent the Royal College of Surgeons as their Welsh representative. As a surgeon and as clinicians in general, I think we're very aware that things could be better and that the outcomes from the services that we're currently providing are in some ways very good, but in other aspects we could be improving. Recently there's been huge improvements in scheduled care, that is patients coming in for planned operations, and the waiting times for that has been greatly improved in the last 10 to 15 years. But one of the costs of that has been that there's been a relatively lack of priority towards emergency care and urgent care. We feel very strongly there needs to be a rebalancing of that. There's a very strong relationship and increasing data becoming available within surgery for there being a relationship between the amount of work which is done in a unit and the quality of the outcomes, so that small units with perhaps single-handed surgeons are getting less good outcomes than larger units with several surgeons working together as a team. And we need to see an equalisation of that and a bringing together of consultants into bigger groups in order that we can have governance of what's going on and making sure that all patients have access to the best outcomes.
My name's Andy McNabb. I'm one of the consultants in the emergency department of Morrison Hospital. I'm also the lead clinician for emergency medicine for Swansea. One of the things that's very clear in my speciality is that there's been a lot of progress in emergency medicine throughout the world, throughout England, over the last 10 years, and to an extent Wales has lagged behind a little bit. Particular areas that are sort of very well known now to be drivers of quality are having an increased consultant presence, which means having units with more consultants. More of the senior trainees in the department, particularly to supervise the less experienced doctors at night. There's a limited supply of doctors both at the middle grade in emergency medicine because of the very onerous nature of the job. It's recognised as being very high pressure. And then at the more senior tier, again, consultant resources are relatively limited. There aren't that many emergency medicine consultants in the UK, and in England it's now standard that units are trying to have at least 10 consultants and maybe more, and units that take a large amount of trauma, as Morrison does, are looking to have 16, 20 consultants, and we're currently a long way from that. Wales has had difficulty recruiting in emergency medicine, as has the rest of the UK. There's an awful lot of patients who come along to emergency departments who have conditions that potentially could have been looked after somewhere else. So we need patients to know more about how to access those services. What we want to do is do the best job possible for the really sick, the really badly injured, because if you concentrate your resources on that, you get much better outcomes in terms of survival and decreased disability.
Cathy, Dowling, Head of Midwifery within ABMU Health Board. We've covered some areas that we feel we're doing really well, and we have got really good quality services at the moment, but actually some areas where we do feel that we would like to improve on. Some of those being particularly around capacity and demand. We've had some challenges with sustainability of some of our services in terms of managing the capacity, particularly around neonates. We've got babies being born at a much lower gestation. We've got a rising birth rate. We've got changes in relation to mums, less teenage pregnancy mums, but actually women in the older age bracket. Obviously we've got midwives and nurses, but we need medical staff as well, so we need the centres that are going to be dealing with the more complex mums and babies to have properly staffed rotas, and I think that's a real issue for us.
I'm Eirlys and I'm Deputy Head of Nursing for Children's Services at ABM Health Board.
I'm Killa, I'm the Head of Policy and Regulation for ABM Health Board.
And our work stream is about children's services. And one of the biggest drivers for us is the lack of middle grade medical cover and the inability to cover the rotas. What we want is a safe, sustainable, high quality service for children and young people. And I think with the shortage of doctors, and we've got to really look at ways of addressing that, and about changing service provision to provide that high quality service. It's about having a service that is local for families, and having the right services in the right place at the right time.
If we stop and think about it, most of the population of children are well and healthy. So what we really want is a service where somebody needs secondary care, they have very high quality secondary care. But what currently is happening, there's a grey area in the middle where children may need some interventions, they may need some investigations, even as something as simple as a blood test, and they have to go into a hospital setting to have that. If we could bring some of those services safely into a community-based setting, then what we'd find then is the doctors within the secondary care setting are freed up to deal with those ill children who need their help.
Okay, my name's Harris, I'm a GP in Bridgend. At the moment our experience is that although there's lots of good services out there and lots of people doing good work, that often the interventions and the processes are too lengthy and are not timely enough. And often that leads to people ending up in hospital where often something else would be better for them. They'd rather be out of hospital. Hospital probably isn't the best place for them to end up. So we do feel that there's probably a better way out there. I think a lot of the services aren't very joined up at the moment. I mean, even sort of having been a GP for several years, if I'm being honest, there are lots of services out there that I still don't even know are in existence, and lots of the system doesn't join up very well. So there may well be duplication of effort by some bits of the service, and other people just not being aware of other bits of services that would be very useful for the patients that they're treating. So we're looking for a more joined up approach, we're looking for a more timely approach, and ultimately we're looking for something that keeps patients independent and keeps people independent and in their own homes.
So I'm Martin Rolls, I'm a clinical oncologist in Singleton Hospital, and the thing that we really focused on was empowerment of patients to take personal responsibility for their condition and to manage themselves as much as possible. There are a lot of patients with chronic conditions. We recognise that there's a spectrum, and some patients are chronically quite ill, some patients are really completely well most of the time. A lot of these patients we're still seeing on a very routine basis in hospital, and to some extent we medicalise their lives when it's not really necessary. And for those patients that are basically well and who are able to take responsibility for themselves, what we want to do is educate them, and so that they understand how to manage their own conditions to reduce the chances of exacerbations, for example managing their chronic diabetes or their asthma. But if they do have problems, then we want them to know how to access the appropriate care. Rather than end up in accident and emergency, they will have defined pathways, have certain key workers or CNSs that they can talk to, and so that they, even though they may not be being followed up on a routine basis, they can rapidly get back into the system should they need it.
Hi, I'm Sean Young, I'm a GP working to the north of Bridgend. There are obviously communities which generate a lot of the work. The sort of communities themselves actually sort of perpetuate the circle of that unhealthy sort of model, with young mothers having children at an early age who then go through that same vicious cycle. They start smoking at young ages, they've got unhealthy lifestyles, they develop health problems early on in their life, and then become our sort of medical statistics further down the line. We're very readily giving people labels or trying to put them through a medical process. We need to build up better sort of routes of access to alternative services, so other methods of helping to support individuals to be healthy. We need to give them healthy options in the community, make access to sports facilities, access to healthy options in terms of eating in restaurants, etc., more readily available, provide good health information in our libraries, etc., so that people are able to go in and pick up a book which will tell them how to look after themselves and make themselves mentally fit and able.
I'm Richard Johnson. I'm one of the consultant surgeons. I think potentially we are offering too many of the same types of surgery and planned care on too many sites, and I think we need to start looking at concentrating services in particular areas. I think there's also better ways of working in coordination between primary care, secondary care and community services, as well as the voluntary sectors as well, to try and improve the whole patient experience. I think the important thing we need to look at in all this process is the quality of patient care that we're giving, which I think is always something that we should be striving to improve. What I'd like to see in future is better coordination between the services I've already talked about, between primary, secondary and community services, so there's a more of a seamless flow of care for the patients, where services are much better planned. That may involve patients having to travel to other hospitals for their sort of major treatments, where we know that if we concentrate expertise in one area, then the outcomes from the interventions that are offered are much better, and far better than the average treatment can be given in more than one site.
When Fiona came, she assessed me and she put together a plan which would help me to regain my confidence. Fiona set up a team of carers to come and see me every day and to help me start off helping me make breakfast, which is brilliant. And as time went by, Fiona got me the carers to help me do lunch, which was brilliant. I was really pleased with the KISS team because every member of staff, from the carers and the occupational therapists and the physios, they were all really kind and considerate. They helped me, none of them made me feel embarrassed or, upset. It was brilliant for me because I was in a kind of vulnerable state. It was always also great that I didn't have to leave my home to get this care, and also the physio come into the house. That was brilliant because I was not really very mobile, and also it helped me live in my own home.
My name is David Fellows, and I've been a renal dialysis patient for just over 6 years. When I started, I was coming into the hospital 3 days a week and doing 3-hour dialysis sessions. 2 years ago, I then started doing the dialysis sessions following training at my own home during the daytime. But in August of last year, which is 2011, I was then trained to do nocturnal dialysis. So when I go to bed at night now, I plug myself into the machine, do it all myself. I have a good night's sleep, and when I wake up in the morning, I come off the machine having done 8 or 9 hours dialysis. In the 9 months that I've been doing this, I feel so much better, and I've got the added bonus of reduced medication, and I now also can eat and drink what I like, so there's real benefits in doing that. But feeling better is the main one. I'm here in the clinic today for my 2 monthly checkup with my doctor, following blood tests I had last week. I'm pleased to say that I haven't got to come for another 2 months following blood test in 2 months' time.
My name is Doreen. I live in Resolving in Neath. I went to the doctors 2 years ago and he sent me straight from the surgery to the hospital. I had an infection on the chest. I was in hospital for a fortnight and I can't remember the name of the doctor. I was in the doctor there and he referred me then to the COPD clinic. They told me at the time there'd be a waiting list and I had to wait 18 months before I went to this clinic. And to be honest with you, I was petrified to go. I thought, I'm going to do all these exercises and make a fool of myself in front of everybody on the exercises. But indeed, to God, I went, and it's good, and done me the world of good. It really did. I was there for a course of 7 weeks, and it's given me more confidence to explain things to you. And it's not like a gym, it's everybody is as you are. They are not well and they don't expect miracles of you, just for you to do your best, and your best you do. It's given me more confidence.
We hope you found this film interesting. If you'd like to know more, please do have a look at our website, www.changingforthebetter.org.uk. We'd like to hear your views, and we're working closely with the University of Swansea so that you can share those with us. They've established a web forum called You Tell Us at www.youtellus.org, and we'd really like you to sign up with that and to tell us what you think of our plans now and over the next few years. It's your chance to help shape your local NHS.